Hello everyone, I am Professor Cliodna McNulty. I'm a medical microbiologist and clinical lead for the Target Toolkit. This is part 2 of the Target webinar on prescribing antimicrobials appropriately during remote consultations. Appropriate prescribing is still just as important now as when Dame Sally Davies was the Chief Medical Officer and championed antibiotic resistance. Today I'm going to discuss how and why we prescribe antibiotics, the evidence showing the link between antibiotic prescribing and resistance in your patients, how reducing antibiotic prescribing can reduce antibiotic resistance and also patient consultations, antimicrobial stewardship strategies you can use with patients, importantly, where to find and how to use the target materials, which I'm going to discuss in this webinar, and the benefits of exploring your antibiotic prescribing in a bit more detail to give you some in-depth knowledge about what you are doing around antimicrobial stewardship. So I'm often asked what exactly we mean by prescribing appropriately in terms of the actual rate at which we should prescribe. This table shows the condition syndrome, the actual prescribing in a UK study using so-called THING data, and the ideal prescription rate proposed by experts in the field within a PHE study and within a European study group, which was the European Surveillance on Antimicrobial Consumption group. So these three groups, we looked at these three groups, and so you've got the actual prescribing, the ideal prescribing suggested by PHE, and the ideal prescribing suggested by the European group. So if you look at acute sore throat, we prescribe in 60%, when we should really be prescribing in only a maximum of 1 in 5 patients. So just to note, an important thing to think about during COVID-19 is that 44% of patients will have a sore throat during their illness. But COVID patients normally have other symptoms as well. Moving on to the other conditions, you can see there's still a big difference, a big disparity between what GPs are actually prescribing and what is recommended. So does it really matter if we prescribe unnecessarily? Take a moment to reflect. Is antibiotic resistance important in your practice? Do you think your own antibiotic prescribing influences antibiotic resistance in your patients or the community? Resistance is now with us in primary care. And actually this study shows that the risk of resistance is over 2 times, here, shown here, 2.4 times, in fact, in the first 2 months after an antibiotic is prescribed for a respiratory tract infection. And is still higher 12 months after that antibiotic use for a respiratory tract. And similar increase with UTI, although the resistance doesn't persist for as long. So in fact, any antibiotic use increases our future risk of carrying resistant bacteria, even if it is just simply amoxicillin use, as often the resistance gene for amoxicillin is often linked to others like trimethoprim. So that explains why trimethoprim resistance has increased in the past and is associated with amoxicillin use. So how do we change antibiotic prescribing? Let's go back to the fundamentals of practice. Why do we prescribe? We prescribe mainly for 3 reasons. Firstly, we want to help our patients to get better. We want to relieve their symptoms, and we believe that antibiotics will help. Secondly, we prescribe because we worry that if we don't, patients may develop complications or more serious illness. We also prescribe because we think patients expect a prescription, usually antibiotics. Let's take a look at these 3 reasons for prescribing and examine the evidence supporting each of these reasons and whether we think it is reasonable or whether we can be reassured by some of the evidence. So first, let's start with the relief of symptoms. So this table again shows a reasonable amount of information, but let's go back to sore throat and I will talk you through it. So we've got 4 syndromes here, which you're all familiar with. And the second column shows you the total duration, if left untreated, of symptoms. And with sore throat, the usual thing is 8 days. However, if you're given an antibiotic, then these people will have improvement of between 12 and 18 hours earlier. That means they may still have a sore throat for 7.5 days. In fact, they usually do have a sore throat for 7.5 days, and they get this 12 to 18 hours improvement. But this doesn't happen in every case. In fact, the number you need to treat to get that one patient getting benefit of 12 to 18 hours is 6 to 20 patients in the different studies. That's called the NNT, number needs to treat. And what's important is that the number needed to harm is actually is only 15. So if you look at some of these other conditions, again, you can see that the beneficial effect is 24 hours or less, and the number needs to treat is even greater than for sore throat. And the number needed to harm is still reasonably low. So we've discussed symptoms, and so the benefit for symptoms is not so great. Well, what about complications? This table is really important and shows the relative risk. That's the RR rate here. For 6 complications: pneumonia, peritonsillar abscess, mastoiditis, empyema, meningitis, intracranial abscess, in general practice with a range of antibiotic prescribing. So column 1 shows the practices for each of these complications divided into 4 groups, quartiles by their prescribing rate, with the greatest prescribing and quartile at the front and at the top and the lowest at the bottom. Column 2 shows the number of those events, so in this case pneumonia, and that's the rate of the events in the next column. Columns 4 and 5 show the risk of the complications, the relative risk compared to the lowest prescribing group, so it says ref, compared to the rest of the group, and 5 is, here we've got the confidence around that and the p-values. So as you can see, I've highlighted the majority in green. And that's because serious complications are actually very rare after respiratory tract infections, sore throats, and otitis media. And so these different prescribing practices didn't have any significant difference in complications rates. If we look at pneumonia, there is an increased risk. And so we've estimated in a practice, this study estimated in a practice of 7,000 patients, there would be a 10% reduction in antibiotic prescribing. And if you did that, you'd get 1 additional pneumonia each year. And there is a small variation in here in the peritonsillar abscess rates there. You can see it's 0.09, so there's some increased risk, but it's not significant. And this suggests there'd be 1 additional peritonsillar abscess each 10 years. So this is why we need to carefully assess for risk of complications in lower respiratory tract infection or bronchitis. And currently, NICE guidance suggests targeting antibiotic prescribing at those at higher risk. For example, those aged 65 or older with 2 or more recent hospitalization, diabetes, chronic cardiac failure, or recent steroid use. But this data does reassure us that complication rates are low in other conditions, and we can be reassured that our appropriate antibiotic use by reducing antibiotic use will help control antimicrobial resistance, and the majority of cases will not lead to increased complications. So most of the really large systematic reviews, as I said, show that complications are rare. But you can use these 2 PHE leaflets, which are examples, which include diagnostic prompts here within your clinical assessment. Here, this is the UTI one. You can use these, and here's the treating your infection, respiratory tract infections. You can use these to reduce risks, and you can use them within your clinical assessment for when an antibiotic is needed. You can also encourage the use of the PHE diagnostic flowcharts. We've got them for UTI, diarrhea, and vaginal discharge. And you can also use the NICE visual summaries. And these help to rule out more serious illness. Also, furthermore, you could use some of the clinical scoring tools. So fever pain can be used for acute sore throat, and that was discussed in the first part of this presentation. And StarWave can be used later, and I will be discussing that. You can also use backup delayed antibiotics. And so You can work with your patient to reduce the risk of complications and give them advice as to when they should go and pick up the prescription. And the PRISM trial, which is one of the largest studies of acute sore throat, shows that if a backup prescription actually gives similar reduction in complications rate compared to immediate antibiotics. So we also need to provide clear advice about duration of illness and what symptoms or signs may mean that urgent care is needed. And these can be reinforced by using the target information leaflets available on the target toolkit. And we've got other ones on for general infection and also leaflets for the over 65s. So I mentioned the diagnostic tools, and this is an example of just one of them. And this is the diagnostic flowchart for over 65s. I'm suggesting this one is a really good one to start with because it's very popular. It's been downloaded from the target website over 50,000 times. And the flowcharts for UTI, first of all, at the beginning of the flowchart, which isn't shown here, stress the importance of excluding genital causes, but asking about vaginal discharge, because they rarely present with a UTI. Also, you need to exclude sepsis and pyelonephritis. And this flowchart really does emphasize the need to not use dipsticks in most patients, and especially not in the over 65s. So the yellow box then gets you to think about and tick if you want to use it as part of a triage system in your practice, highlights the importance of checking for each of the symptoms and signs, and also then also asks you to check if they've got a urine catheter, to check for blockage. So this flowchart and others are on the RCGP target website. And this flowchart also highlights the importance of always sending a urine culture in this group if antibiotics are started. And so it's also useful for, as I said, non-medical prescribers and to set up telephone triaging. So really good. And there's one for under 65s as well. So moving on really to say a little bit more about not using urine dipsticks. Here we present a case study of the Baines region who successfully eliminated use of urine dipsticks as a UTI diagnostic tool in over 65s. They had an improvement program which improved diagnosis of UTI with reduced dipsticks and use of red top bottles which contain boric acid for preserving the urine when they did urine cultures. They improved communication between GP practice and the care homes by using the flowcharts and using a triaging. They encouraged good hydration, so avoiding acute kidney injury, and they concentrated on improving antibiotic use. And so they found a reduction in antibiotic use for UTI from 1 in 2 residents to 1 in 4, a reduction in long-term antibiotic prophylaxis for UTI, and an overall reduction in antibiotic use. More importantly, I want to highlight for you is that they also had reduced calls to GP practices for inappropriately diagnosed UTI. So that gives you a chance to do other jobs instead of talking about UTIs in care homes. So it's really worth discussing the use of the flowcharts and leaflets with your staff and in care homes and get them more widely used in the community. So here are some of the patient leaflets, and they're useful tools to help guide and direct discussions within the consultation and for patients to take home. And just to note, we have modified all the leaflets to make sure that we discuss, that COVID is covered in these. And as a result of pharmacists actually saying to us, could they have a leaflet on how can I manage my common infections? We have one which helps patients to think about all infections that they could keep at home. So please do use these. So I mentioned other scoring tools for helping to reduce complications and hospitalizations. This is an excellent study published in The Lancet, and they're currently doing a follow-up study with it in even a greater number of children. So this was in over 8,000 UK children. And they looked at complications, and they were looking at predicting future hospitalization among children who presented to in-hours primary care with acute cough, and respiratory tract infection. And it was really developed in response to primary care clinicians saying that they prescribe antibiotics just in case the children's illness deteriorated, and because they obviously, as I said, they were worried about complications. So this tool has very good prognostic properties. No clinical test or decision tool is absolutely perfect, but where used, we believe it could support, although not replace completely clinical judgment. So they included children with stable or infected asthma, and children, although children at high risk of complications, so immunocompromised and cystic fibrosis, were excluded. So 0.9% of children were admitted for their RTI in the following 30 days, and they looked at complications rate, and they found 7 symptoms and signs which were predictive of the probability of children being admitted to hospital. And so you've got short duration of illness, temperature, age under 2, clinician reported recession. Again, you know, if you've got a video consultation, you could look at this possibly if you're not seeing the child directly, but it would be better to see them. Clinician reported wheeze on auscultation, a current diagnosis of asthma, and severe vomiting in the previous 24 hours. And if they had a score of only 0 to 1, they were very low risk. 1 in 320 were then admitted. And this is actually 67% of patients. 30% of patients had a score of 2 to 3, and they call that normal risk, about 1 in 70. And that suggests a no or delayed antibiotic. So a child under 2 with asthma, plus or minus a wheeze, you might well consider a delayed prescription in those children. Then with a score of 4 or more, about 3% of children, so that's a very small number, they're suggesting that they should be closely monitored for signs of deterioration, as 11% of those were admitted. So monitor and give immediate antibiotics. So this is a really useful tool, and I suggest you use it. And again, it's on the Target website. So we discussed patient pressure. So most importantly, very recent data shows that patients trust pharmacists, nurses, and GPs' advice as to whether they need an antibiotic. Therefore, it is worth sharing the need or not for antibiotics and discussing self-care in consultations. So this is a January 2020 publication. So will reducing prescribing antibiotics in respiratory tract infections benefit you? This study shows how rate of prescribing antibiotics in 537 UK GP practices over time for acute coughs and colds, shown in red, runs in parallel to consultation rates for these infections, shown in blue. So think about your own prescribing. How often do you use amoxicillin for coughs? In this study, there was a marked variation in the percentage of patients in each practice that were prescribed antibiotics. And that variation was in fact not influenced by age or social group or deprivation. The variation in practice antibiotic prescribing still persisted when those were allowed for. And what was interesting, in a longitudinal study, practices who reduced their prescribing experienced a reduced consultation rate. So thus patients can be retrained not to expect antibiotics. And this helps you reduce your consultations and workload, or at least allowing you to concentrate on other things. So I think it suggests that we could all probably improve our antibiotic prescribing, that those at the higher end of the range could do so more than others. So think about your own prescribing. Do you think you're at the upper end? And if you are at the upper end, you could, really think of using CRP. And if you think you're similar to your other CCG colleagues, what about elsewhere in the whole of the country? And I'll show you some other data showing that, and it'll be worth looking at that for yourself later. So I mentioned backup prescribing already. Many systematic reviews have been published showing the benefits of this approach in reducing unnecessary prescribing. This study shows that cough duration was similar in patients given none, a delayed, or an immediate antibiotic. And there was no difference in recovery rates and high levels of satisfaction with all strategies. Overall, there were fewer reattendances with cough following delayed prescribing and immediate antibiotics in the month after the physician visit compared to no antibiotics. This is another UK study of 315 children with acute otitis media. We know that people do prescribe for acute otitis media and ear infections, and 58% of the general public this year in January 2020 said they would expect to receive an antibiotic for this condition. On average, symptoms resolve after 3 days. Children prescribed antibiotics immediately did have a shorter illness, 1 day less at 24 hours shorter, and fewer nights disturbed, actually 0.72 of a night, but it did vary, and slightly less paracetamol consumption. But there was no difference in school absence or pain or distress cause, since the benefits of antibiotics occurred mainly after the first 24 hours when distress was less severe. So although there were differences, we're saying that it didn't make so much of a clinical difference as you would expect. So what about backup prescribing? What do the public think? Well, this survey of the public in 2020 showed that 4% of 2,000 members of the public reported being given a backup delayed prescribe. That's equivalent to about 2.5 million scripts per year. So the strategy is being used. So I'd recommend its use. And also, most importantly, as you can see from this Venn diagram here, 48% did not take the delayed antibiotic. And out of the, and most people actually also said that it was very acceptable to them. And only 1 in 10 said that it was unacceptable. So how should we give a delayed antibiotic script? So we can ask patients to recontact the surgery. We could post date a written prescription or write instructions on the electronic prescription, asking that it should not be collected before a certain date, or it is only valid for a certain time. That means that the patient won't go and pick it up, and you won't go and pick it up in 2 months' time, or they can't do so. You could ask the patient to collect from the surgery, slightly more tricky in COVID times, or you could give the patient a prescription, handing over complete control. So what happened when we compared these? So this is the PIPS trial by Paul Little. Antibiotic use is very similar, whatever strategy you use, being lowest with the no antibiotic option. But satisfaction is actually greatest with the patient-led option. But there was no significant difference in this outcome. So use what's convenient for you, and remember you can write instructions on the electronic prescription for the pharmacist. So what are the common concerns with delayed backup prescribing? Well, the first thing, it is not as effective as no offer of prescription. Well, actually, yeah, there are slightly higher rates of antibiotic use, but we'll have to say that, but it is fine. But it will certainly reduce the number of patients who come back to see you by a third. What about medico-legal consequences? Complications. Actually, as I mentioned, there's similar reduction in complications compared with immediate antibiotics. 2 very large cohorts show that this is the case, as especially with patient control, they can collect the antibiotics as soon as they're needed. A study of use in UTI showed that similar cases of pyelonephritis if delayed antibiotic scripts were given with a non-steroidal anti-inflammatory drug. So I think it is important to give a delayed script if you just treat with a non-steroidal for pyelonephritis. The last criticism is it takes more time. Most of the 6 R's, which I'll discuss in just a moment, you should be doing anyway. The key difference is advice about when to consider cashing it in. And I think when you get comfortable with it, it will become much easier to you. So Paul Little's advice is try it. Patients like it and you'll get quicker. A bit like green eggs and ham. Try it, Sam. You'll really love green eggs and ham. Anyway, it's easy, but do it properly and you will then reduce antibiotic use. Remember the 6 R's, most of which are simply good practice. Reassurance, reasons not to use antibiotics, give pain relief, paracetamol and limited non-steroidals. Think about who you give those to and side effects. give patients a realistic natural history of how long you would expect the illness to last, and they're less likely to come back to you. And reinforce key message, that is, only use the delayed prescribing if getting worse or not even starting to settle in the expected average time. And you can use the leaflet, the leaflets that we've got to help you give delayed prescribing with respiratory tract infections. So aim it to keep it for only the 20 to 30% when you are unsure. We're not saying you should be using it in everybody, and then check to see how often you are using it. So it will certainly reduce complications and save you time. So it gives certainly fewer complications than no prescription, and you'll get fewer repeat consultations compared with no prescriptions or immediate prescriptions. So I've mentioned the target website on several occasions already. This is the landing page. It has a bit of blurb at the beginning where it tells you how the website was developed, but it's easy to find your way around. So you've got the target guides and updates and news. People are very keen on the UTI resource suite, and as I say, 50,000 of the UTI flowcharts have been downloaded since we published them. The leaflets to share with patients are the most accessed. There's resources for clinical waiting areas, less useful now at the moment because of COVID rules and regulations, so we'll be looking at that. So look out for updates over the next 6 months. There are audit toolkits and self-assessment and action planning, really useful. And some CCGs have used those for all the practices. There's the antibiotic and diagnostic quick reference tools. So there's a link to all the nice antibiotic guidance from there and the summary tool. There's training resources like this training will be there, and other training around UTI, etc. There's one for target trainers and training, and some information for commissioners. So do visit it, and I will discuss a few of the things on the website in a bit more detail. Sorry, I've gone the wrong way. So this is the self-assessment checklist. It's a tool for you to decide and measure how far you are along the road to optimizing antibiotic prescribing in your practice. And it highlights some of the different strategies you can use and how you can find resources to support them. You may wish to go to the website and do this after this webinar, or ask others in your practice to do this before a meeting to discuss your results. And it's on the website in several different formats. You can download it in this hard copy form, or you can do a digital format. And it gives you feedback about what you can do while you're doing it. So next, there's the target audits. I've mentioned them already. They can be used to identify how compliant prescribers are with PHE and NICE prescribing and diagnostic guidance. The audits can be either done on a Word document, or you can complete it on an Excel document. And if you do it on the Excel, it will automatically calculate your compliance against guidelines. So these are really useful to find out exactly when and why you prescribe, and can be used towards your CPD and improve patient care. The UTI audits, there's new UTI audits, and they're going to be published extremely soon. So there are now many ways you can explore your antibiotic prescribing in a really useful way to help inform what audits you may wish to undertake in your practice. You will mainly find using prescribe, PHE fingertips, and open prescribing the easiest to use. And I'll go through those just briefly now, and I'm not sure how much you've used them, and you can speed through this section as much or as little as you like, but the medicines managers will definitely find them useful, and you may be able to identify an antibiotic champion in your practice to do some of the audits, or initially actually go to these websites to see where you need to change your practice and then do a more detailed audit. So this slide down the bottom gives you a link to the prescribe website, which gives you the most of the data that will help you inform and then improve your antibiotic use. And as I said, this could be done by your local manager, medicines manager for you. So when you click on the link, you then need to choose the data that you want to look at. And there's a bar going across the top. I've expanded it a little, but this one, in this example, I've suggested we look at a GP scatter plot. So there it is. You will then need to decide on select the country, and I've picked England only here. And then the commissioner grouping. This one says STP Greater Manchester and PCN cluster. Again, so there's the cluster. Again, I've selected all. If you want to be more selective, you can highlight specific CGGs and you'll have far fewer practices down here in the scattergram. So there's the PCN. So this is a fantastic graphic to show you where you and how your practice compares with others. For total antibiotics in the vertical axis up here, and the proportion in the horizontal axis, the so-called 3 Cs, what proportion of the total they are. And it also gives you the national so-called best practice targets. So 10% as the proportion for the 3 Cs. And here you can see the target for prescribing for the country. And it tells you exactly where your practice is. And what's great with this is that you can actually then, you can actually click on a practice or an area and it will come up here. So it has a cursor. So when you click on it, so we're clicking on this triangle, this comes up and it says it's NHS Salford. And it says it's above the 10% for the 3 Cs and it's above the 1.16 for antibacterial items and 1.37. So, and it gives you the actual statistics. So it tells you exactly where you are and exactly what you need to do. And so you can use that to inform your practice. And here you can then go to the target website and say, well, actually, I think I need to do a 3 Cs audit. And coming soon will be a 4 Cs audit, or it may well already be there. So the 4 Cs audit on the website that you can then do and identify maybe what you're doing incorrectly. Also, you could look at more detail here about your prescribing. In this example, I've suggested we look at bar charts by primary care network. And in the same way, I have, as before, selected here STP Gloucestershire, and this is NHS Gloucestershire CCG. And this shows the GP practice's total antibiotics by star PU, allowing for list size and age, and the proportion of coamoxiclav, cephalosporin, and quinolone items. So using the website also, you can actually look even more carefully at a time period and trends of total antibiotics. So for one particular antibiotic, by CCG, primary care network, or by practice. So there's lots of different things you can do. Okay, so the national guidance is advising increased use of nitrofurantoin. You can use prescribe or visit fingertips to examine your nitrofurantoin and trimethoprim use. Your local medicine manager can also produce graphs like this one. And this shows you can have a look and see how you compare with other practices similar to you. So why do we need to actually use nitrofurantoin first line for most patients? Trimethoprim resistance shown here has increased until 2015, and especially in the over 80s. So peaking at 48%. Since 2015, resistance to trimethoprim has dropped, but not enough yet to recommend its use empirically. So this is evidence, the fact that it's dropped, that decreasing use in the UK can help reverse upward trends in antibiotic resistance. However, remember, nitrofurantoin should not be used if upper UTI is suspected or the eGFR is less than 45 mils per minute. Another choice may be in those situations to use pivmecillinam if your laboratory undertakes susceptibility testing, furthermore, all the patients should be told to come back to the GP if their symptoms haven't improved by 3 days or they're getting worse. And again, you can use the UTI leaflets for safety netting. Remember, however, I'm not saying never use trimethoprim. You can still use it if you've got a susceptibility test, which you will want to always do if you give empirical antibiotics in the elderly, or sometimes in younger patients where you think that the risk of resistance is very, very low. It would be really useful to do your own audit of your practice results to see how many women with suspected UTI have had a culture result, what they're prescribed, and the clinical outcome of patients with UTI. So I mentioned pivamycillinam now. Again, you or your medicine manager can also produce graphs showing use of other UTI agents on prescribe, or get your medicine manager to show you. So you can have a look and see how you are doing compared to other practices. As you can see here, this particular practice is using a lot of pivamycillinam, and other practices are using an awful lot of cefalexin. And the importance of that is that cefalexin should only be being used for pyelonephritis and not as empirical treatment for UTI, for lower UTI. So here's fingertips and the local indicators. So since April 2016, they've launched a lot of indicators around AMR, prescribing, healthcare-associated infections, infection prevention control, antibiotic stewardship. And so these are really important. And it's only fingertips, and there's the link here, that look at all these different parameters. So this graph, for example, shows broad spectrum antibiotics versus Clostridium difficile rates and shows how they are related. And it allows comparison by CCGs and all the AMR indicators and other public health data available. So really useful data. Fingertips also gives you local antibiotic resistance data. This one shows you the percentage of community E. coli or coliform urine specimens resistant to trimethoprim by quarter. So you can keep an eye on your resistance rates. So, in conclusion, what are my key 2020 antibiotic prescribing messages? So backup prescribing works. Try it, you will see. Like Sam I Am, Dr. Seuss book, my favorite. Reducing prescribing helps reduce workload. The benefit achieved from prescribing antibiotics in otitis media in children is small, but remember to use star waves. It will help you look at risk for hospitalization. Do not use dipstick over 65s, but use the UTI flowchart. Prescribe doxycycline for acute cough. I'm sure Tessa mentioned that in the last webinar. Prescribe cefalexin for pyelonephritis. And develop an action plan on how to use the diagnostic flowcharts, leaflets and audits in your practice. So take a moment now to reflect on what you can do to improve antibiotic use and help control resistance. You can pause the webinar now and write a list of what you think you should be doing. So firstly, I would suggest, well, I'm not suggesting actually, these are other things other people have suggested, and we have now added to the webinar. Make sure everyone has access to antibiotic guidance. Use the diagnostic flowcharts to help patient triage. Use backup delayed prescribing, and the leaflet will help. Use leaflets to safety net and increase patient understanding. Develop computer prompts to increase use of leaflets and flowcharts. Your CCG or your practice may have a contract with Accurix or Ardens, and they're doing many things at the moment. Use fingertips or prescribe to monitor usage, and do an antibiotic audit with action planning. So when you've considered that, actually decide now who will be responsible for each of these agreed actions, and take a moment to really think about that and put your enthusiasm and your motivation, which you've got now, into action to make a difference. So many thanks for listening, and to everyone at the RCGP and the Primary Care and Interventions Unit where I work for facilitating this webinar. And don't forget to visit the RCGP Antibiotic Target resources, and pause the webinar at any time and go back, find the links, and really do use the resources. And you'll find that your antibiotic prescribing will improve, and you'll find that within your CCG and nationally, you'll start within some of those scatter charts to be going down towards the bottom left. Thanks everybody, and look after yourselves, stay safe, and keep antibiotics working. Bye.